Welcome. This is the iTero digital workflow for partially and fully edentulous scanning. It is going to be a webinar and training presented by Kelly Bevington, RDA, EFDA, with support from Brittany Carey, RDH. She is our iOS clinical training specialist. And we're going to begin the webinar shortly. And just in case you just popped in, I'm going to introduce one of our panelists is Brittany Carey. She is an iOS clinical training specialist. Feel free to chat with her and ask any questions or comments in the Q&A too. And now it is my pleasure to introduce Kelly Bevington. She is the director of iOS clinical training team. Kelly began her career more than 20 years ago as a RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices and is able to provide expert chairside coaching. She manages the NDS clinical iOS training team and has clinically trained over 1,000 dentists and their team. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And with that, it is my pleasure to say, take it away, Kelly.
Thanks so much, Jessica. I always appreciate the kind words, and thank you everybody for registering and being here this evening. Brittany, so happy to have you as part of the team and, you know, co-presenter, watching the chat and helping me manage and answering questions as well. So
my pleasure.
Start with a relatively short PowerPoint presentation and then go into a demonstration. I've already started some scans and then some I'm going to do live. It lags a little bit when you're scanning live with the whole technology aspect, but we're gonna give it a good go and answer questions, right? I really encourage you to be engaged with us and ask opinions of what we've experienced in the field. We are both certified trainers by Align Technologies on the iTero scanner, and the whole scanning of partially edentulous and fully edentulous patients is still new, right? It's an evolution that we're going through. Just like you know, we shifted from rubber base to polyether and polyvinyl siloxanes. We're now migrating and evolving through the different types of edentulous and partially edentulous scanning we do. So with that, I'm going to go ahead and get started here. A little bit of the housekeeping, as Jessica mentioned. Both Brittany and I are full-time employees here at NDX and presenting tonight's program. So for those of you that don't know, NDX is the nation's leading laboratory group with over 65 separate locations in the United States. And we have a team of clinical training experts, meaning we're all credentialed dental professionals. As Jessica mentioned, I began my career as an RDA EFTA. Brittany is a registered dental hygienist. Brenda, who covers the Midwest region, is a certified dental assistant and RDA. Was a faculty member teaching digital scanning in University of Detroit, Mercy. And then Bannister Poe is, he was actually a dentist in the Philippines. And then he came to the US and has worked with 3Shape, which is the Trio scanning system, and Nobel Biocare. So great source for implants. So we're going to talk specifically about iTero scanning tonight. My device that I'm using happens to be an older version. It's an E1, Element 1, so it's a little slower. And it is the same software, though, that even the 5D would be using as well. So some of the key things that you want to be aware of, and this is snippets from a document that is being sent to you as a follow-up from today's presentation, and it comes from Align Technologies. So there's two different recommendations or school of thoughts when it comes to fully edentulous scanning. One is to scan the denture itself with a wash impression or a chairside reline material inside of the denture. So you're going to scan the occlusal surfaces of those denture teeth and the intaglio of the denture. The tricky part is capturing all of the border molding that you've done with that wash impression, right? To capture the muscles that you would ordinarily get in your custom tray impression. The second challenge, if you will, is to go very, very slowly. So mentally, we've been taught now for the last many years to scan quickly, right? And everybody wants to scan a little faster, a little faster, a little faster when it comes to full arch scans for Invisalign or splints or even crowns and bridges. You want to be effective and proficient and quick. You want to be the opposite, really, when it comes to scanning fully edentulous, whether it's scanning the denture itself or you're scanning the oral cavity. And part of the reason for that is the scanner is not picking up the color of the tissue, it's picking up topography, right? So the little nooks and crannies of the oral cavity. If you've had recent extraction sites actually scan really well. If the patient has a well-developed rugae on the maxilla, that's very helpful in scanning. Where it becomes difficult is as we migrate posteriorly to the postdam area and where that seal of the denture would be, and the hamular notch, that can be more cumbersome to capture for a couple different reasons. One, you have to keep the oral cavity really dry. And for some patients, that's more difficult than others. And secondarily, if a patient, for instance, has been wearing a denture for the last 20 years, their palate is going to be super, super smooth. And it can be almost impossible to capture that data today, right? Today, I anticipate with the software changes and upgrades that we've seen in the last year, and I'm going to mention one of those here in a moment, artificial intelligence and the ability to turn that on and off, that in the next 6 months to a year, we'll be having a completely different conversation. I mean, it's going to improve pretty rapidly. I think there's a desire for that knowledge in our industry. So I mentioned you can scan the oral cavity or you can scan the denture itself. So a lot of people will say to me, well, what's the point of doing that if you're taking an impression inside of the denture anyway? Well, think of that denture as being like your custom tray. And the benefit is that your patient is not going to have to go without their denture. Could you pour that impression up in your office and let it set and separate it and clean the denture and give it back to the patient? Absolutely, absolutely you could. In my experience, it's becoming, I see less and less dental assistants with that skill set to be able to pour a denture impression, for instance. So that's the benefit of doing this type of process in scanning the intaglio of the denture, as well as the opposing, and then capturing your bite. So you would put your denture back in the patient's mouth to actually capture the bite. And again, I'm going to go through that as a demonstration as well. Please know that in the notes section, you can indicate any type of notes that you want to. You can also take a screenshot of some different information that we see on the screen after our scan. And an example of that might be the patient has an existing denture and maybe the midline's off a little bit, or now their bite has a little bit of a cant. You can take a screenshot, make some annotations, both in text and draw a picture, and we'll do a demonstration of that as well. And so it's really a great communication tool. So when it comes to sending this information to the laboratory, you really have lots of choices. In some cases, the laboratory might be able to go directly to a try-in with teeth set in place. Maybe it'll be a try-in, which is the anterior teeth set in place, and posterior bite blocks if you really needed to like increase vertical or change the existing bite registration pretty dramatically. Let's say you don't get a very good impression scan, whether it be intraorally or of the denture itself. In that case, the laboratory may reach out to you and say, hey, we can provide you a great custom tray at this point, but not enough data was acquired to actually go to a try-in. So just to keep those things in mind so that you're aware of that as well. And I would encourage you to contact your dental laboratory, hopefully it's an NDX lab, and ask them what they're comfortable with, right? What's their next step that they recommend after receiving your particular scan. It's going to vary from location to location with their level of expertise and whether they are doing their try-ins in a more traditional way, or if perhaps they are doing some printed try-ins as well. So this is an example. I'm going to move my here a moment. This is an example of it's a maxillary case that I will be scanning, and that this one I already have scanned. So you can see the difference between the pink and the yellow. So the pink was a more rigid material, and this was a hands-on workshop that we actually did. So we border molded with the heavier body polyvinyl siloxane material. And then the yellow was more of a light body to flow. And that process worked well. It was on a cast, right? So it's on a plaster cast, a stone cast, not a human. So you will notice that, you know, some of the replication of the muscle, you know, it leaves a little bit to be desired because it was not done on a real person. So full disclosure there. And then the lower was a cast, and then we did a traditional bite registration where the upper denture was put back on that cast and the bite was taken at that time. This is what I mentioned about the capability to take a screenshot of what you see on the screen and how you could potentially communicate to the laboratory. So in this case, I just created something and asked that the midline be shifted to the left by 2 millimeters. But really, anything that you might want to do a drawing of, and I know there's lots of creative dentists out there because I've seen your RXs before. Really, anything that you could put in print, you could draw on this image or picture as well. Okay. And the same thing goes for partial dentures, right? So with a partial denture, you can take the scan. So this is the scan, again, a maxillary case. Most successes that I have experienced personally have been maxillary cases. You have better bone support. When I've gone to scan fully or partially mandibular cases, if the bone has resorbed tremendously, it's very difficult to capture that mobile, flopping, moving, wet tissue. It's really, really challenging, and contending with the tongue all at the same time. Although the wand itself does a really good job of retracting the tongue, allowing you to capture the ridge, it's the movement of that tissue if too much bone has resorbed. So this is a maxillary case, and this is just a partial design that a dentist I was working with created for this particular one. And I see a question here. Does that screenshot image with the written notes go directly to the lab with the digital scans? Wonderful, wonderful question, Paris. And no, as a matter of fact, it does not. So where it goes, you save it. So the image up here to the right-hand corner looks like a camera. The image, when you save it, goes directly to your myitero.com account. So you log on to myitero.com, your image is there, and then you would email that to your laboratory. At this moment, it does not tag along with the scans from the case. I anticipate that to change within the iTero software sooner than later, but I don't have a definitive date as to when that will be occurring. Great question. And what other questions might we have prior to me going to the scanner itself? And truly, I want this next part to sort of be collaborative, right? So if you've experienced something that was super successful and I happen not to mention it, please feel free to jump in and help us all become better at the scanning that we're doing. So I'm going to open a couple orders up that we have. Oh, and before I do that, I do want to make sure that you are aware. It really sounds like we have a very experienced group, but in the event you're not aware of the green question mark here in the upper right hand corner, that I can't tap on it now because that's how I'm sharing the screen from my iTero scanner. But anytime you would like one of the NDX clinical trainers to be of assistance to you in a remote fashion, we can team viewer into your scanner, just like I'm team viewering into my own right now, and discuss a case with you, right? Or even be there while you're scanning and offer some coaching that way as well. And of course, we're available for in-office chairside scanning assistance as well. All right, so I'm going to go to the orders that I have already set up. And the first one I'm going to jump to is the full upper denture that has a wash impression. In my little hourglass here, a moment to kick in. And it will go through the post-processing. Okay, so we have the upper scan, right? Nice muscle attachment. We've got the post-amp palatine seal, and we have all of the occlusal surfaces of the denture itself. What we don't necessarily need is the rest of the palate on the tongue side, right, from the exterior. And the reason we don't need that is because there's nothing that's really going to be duplicating that part of it. So it's difficult to capture. So the depth of the patient's palate is really going to make a difference. As all of you that have iTero scanners know, the wand itself must be touching the surfaces that you're scanning. So if the patient has a very high vault of their palate, it's going to be challenging to capture that, whether it be intraorally or scanning the denture itself. And I'm sorry, there's a chat question here. What are the steps for the edentulous person who does not have a denture? So great question. And that process is going to be to scan the oral cavity, right? You could take an impression and scan the impression and send that. It's important to you to keep the entire workflow digitized, but it's not necessary. You could also, so you can take a physical impression, or you could scan the oral cavity. To do a full mandibular scan of a fully edentulous patient, I think would be very difficult. A maxillary scan is doable. You just need to be careful that you're not retracting the cheeks and lips too much, because then you're going to lose the replication of how the muscles should be reacting when the denture is in place. And then if we are scanning a patient for a partial, then we can call NDX lab before the patient's dismissed. Possibly yes. I'm not going to promise that one. It's dependent on time, right? So it takes a certain amount of time for the scan to arrive at the lab, you to coordinate that call. I would suggest instead of just calling and waiting to dismiss the patient, that you pre-schedule something with the laboratory and just call the lab and say, hey, I'm going to be doing a scan. I should be finished up around 1:30 today, and I'd like you to be able to take a look at it before I dismiss my patient. Can we coordinate that? I think that is very doable, but just to call and hope that the person or people that are the experts in evaluating your scan are available at that moment. I'd hate to put you under that pressure or the patient under, those kind of timelines for dismissal. Okay, so again, taglio of the denture, right? We have the lower cast as well. So this is just my lower cast, and then our bite registration. So I wanted to show you that, and I did that earlier today before today's presentation. So the screenshot that I mentioned, I'm going to take the lower off. And the screenshot that I mentioned is the camera up here. So now I'm going to open the screenshot. And then this is where you can do editing with the actual image that you see. So I'll start with my text box. I'm going to shift the midline 2 millimeters left.
Hey, Kelly, really quick, would you be able to move your mouse cursor over the icon, the camera icon, to show them what you selected to get to this, to take a screenshot?
Let me attempt it. So I was touching on the screen itself versus using the mouse on my computer. So now I'm using the mouse and it's disappearing when I get to the screen. Let's see.
You might have to enable it in the settings up top if you bring down that banner again.
Under annotate, maybe?
Should be a little checkbox, I think. It's been a minute. Under view, I believe.
Okay, sorry, I'm in
Show
view.
remote cursor.
Ta-da!
Perfect.
Teamwork, thank you, ma'am.
Of course.
Okay, how's that?
Perfect. If we
Yay,
could just
okay.
minimize the banner again.
Yep. So this is the camera that I mentioned, right? And I have put the text box in place. So let me get rid of this one here. So I've got the shift the midline 2 millimeters to the left, and then I can actually draw and select a color. Not a very good drawer with my computer mouse, sorry. But to give you an idea that that's what you could do, right? And then when you select keep annotations, that's where you see that screenshots and annotations will be uploaded to myitero.com. Okay, so that's where it goes now. Super. All right. So I'm going to close out of this one. Okay, so I've already scanned the lower, so this is going to be my opposing. And now I am going to scan the upper. And this one is for a partial. And then I'll go back to the denture. And you're still going to stick with the occlusal lingual buccal as a scan path protocol that you ordinarily do with iTero. Sometimes with partials, you need to go a little more lingually than you ordinarily might if there's a large span of edentulous tissue. Some people like to activate or disable the AI for removable partial dentures. I'm personally not as much of a fan. What I have found is that when the patient does have a considerable amount of natural dentition remaining, it can be difficult or challenging, I should say, to capture the difficult not to capture, rather, the lips and cheeks, tongues, and fingers, right? Once you disable AI, and why, so let me back up and explain why you would disable AI. When you're disabling AI, it's telling the computer software and iTero modeling and interpretation that you want to keep all of the data that you're scanning. So currently, you do not, the technology has become so wonderful that if you accidentally scan your finger or a lip or a tongue, it takes it away, right? It automatically takes it away. And that's the power, the great power of artificial intelligence. So oppositely, when you're scanning edentulous areas, the computer does not realize that it's edentulous, right? It's looking for teeth. it's looking for that topography that we talked about earlier. So that's why you would disable AI. And I'll show you where to do that here in a moment when you're scanning for that fully edentulous patient.
Kelly, we've had a couple questions.
Yeah,
I
go
just
for
want
it.
to interrupt you. First question is, any tips on getting the mesials and distals between spaces where there are missing teeth?
Yes, I'm going to show you right now, as a matter of fact. So we can see the blue here, right? Let me get my cursor back up here. So this is the blue, right? This is missing. This is missing here. So there's something called fill tool. I'm going to be pressing and holding on the screen of my device. Gonna make a liar out of me. Come on. Let me do a quick post-process and see if that makes a difference. So I've already got my lower. I'm going to go ahead and do the bite registration, and then I should be able to do that for you, to show you the fill tool. So I'm going to take my bite registration. I'm doing it once on the right side and then once on the left side. Okay, so there we are in a complete occlusion. I'm going to go ahead and post-process. So that's the image with the magnifying glass. And now let's go back to the maxillary scan and try that fill tool again.
Oh, Kelly, you're in post-processing.
Ah, thank you. I did want to post-process, but not to show fill tool. Thanks. There we go. All right. So pressing and holding on the screen, it is the third image down. And it goes away quickly, as you saw. So it's a third image down. I'm going to select fill. And can you see how it's encircled? So those holes that we saw that's in blue are now encircled in red. And we need to go back and capture that relatively quickly. And it will turn tooth colored as it begins to fill. And you can leave that on, right, and go to different areas to capture that as you're going along. There. That one. And like oftentimes it's the distal of those second molars as well. Great. I hope that was helpful. Was there a follow-up question to that, Brittany?
Not a follow-up, but there is another question. Is it better to scan in stone mode versus color mode for partials and or dentures?
Yeah, good question. So I personally prefer to scan in color. As a dental professional, I'm accustomed to looking at gingival tissue and teeth. However, that being said, it's critically important to look at your scan and evaluate the scan in the stone model or monochromatic, because truly that's going to be the way that the laboratory is going to be looking at it. Does that make sense? And Brittany, I'll ask you your opinion. I mean, really, it's you can scan both ways. You can scan in color or you can scan in stone model mode. And it's designed that way on purpose for personal preference.
Right. That's exactly what I was going to say. It's personal preference. For me, I enjoy scanning in monochromatic in the stone versus color. Kind of helps me not focus on, because I'm a hygienist, not focus on maybe, you know, how the tissues are looking and the health of the tissues or any buildup that I might be seeing.
Yeah.
Keep me on track.
Yeah. Yeah, that's really interesting that you say that, because little off topic. I just did a training last week and it was with a hygienist and it was a full arch scan. Younger patient, but the patient hadn't been to the dentist in a long time. And so she wanted to scan the patient first and really be able to show the patient the calculus that had built up, right? And then she did a quick lower scan again. It was the lingual, the lower anteriors, after she removed the calculus and showed them both. And it was really eye-opening. I thought that was a great education tool. Again, bit off topic. Do we have another question before I move on?
I'm not sure if it's a question. Maybe they're wondering if we have any scanning tips for someone being seated for brand new dentures instead of previous.
So new denture scanning tips. Patients never, let's say they've never worn a denture, or maybe they've lost their old denture. Again, if it's the maxillary arch, I think you have much greater chances of success versus a mandibular arch that has a lot of bone resorption. This is really the time, in my opinion, to make use of four-handed dentistry. So in many practices, it's the assistant that's doing a lot of the scanning, and in most cases that works out wonderfully. It can be really hard to scan a fully edentulous patient and manage the lips and tongues and scan at the same time. So there is something called an Optragate, and it is, if you've attended any of my our other presentations, it is a disposable item, and it helps to retract the lips and cheek. There's also another device called ScanMate that's more of like an instrument. It's an autoclavable black rubber handled item that you would sort of use like a mirror, except there's no reflection to it. The other tip I might have, and it's funny because like I know the people from iTero are like, nope, it doesn't have anything to do with the use of this next item that I'm going to mention. But it slows my mind down enough to follow a path. And that's something called a Dr. Thompson stick. Sort of looks like a little toothpick with indelible ink at the one end. When you moisten the end, you can then use that tip to draw on the patient's palate, right? Like I like to make X's and I follow the X's, or perhaps almost like a Christmas tree kind of mode from the Potsdam Palatine line, and zigzag on the palate left to right, ending behind the centrals at the rugae. So those are a couple things that I have had success with. Again, that's not like an iTero sanctioned recommendation. They sort of think I'm crazy when I do that. But again, it slows me down because I'm trying to follow the path that I drew with the Dr. Thompson sticks. And in slowing me down, it then allows the images to stitch together on the scanner itself.
We have a couple more questions. Really appreciate your guys's your questions. George says, trying to eliminate conventional impressions, how do you handle border molding techniques?
Yeah, so the only experience that I've really had, Dr. George, it is with an existing denture, right? So we'll take the existing denture and use a heavier body material where you would border mold, right? And so you could either do it in a two-step technique, or you could put the heavier body along the perimeter of the denture and then the lighter body on the intaglio, put the denture in place, and then have them go through their, AIOU, everything that you would ordinarily do to create that border molding experience. I have not had an experience in doing border molding for a patient that is already fully edentulous and does not have an existing denture.
Perfect, great question. Back to the edentulous patient, after the oral cavity is scanned or the impression is scanned, they're assuming that the next step is to get a trial denture base with a wax rim from the lab. And then the wax rim is adjusted for vertical dimension. Is the wax rim then scanned for vertical dimension?
Great question. So it can be a couple different ways. So it could be a traditional wax rim and bite blocks, right? Or sometimes the anterior teeth might be set. You don't necessarily, so after you adjust the white, the wax rather, for adjusting the vertical dimension, you don't necessarily have to rescan it because it is now a physical record. So you're going to be sending that wax bite block back to the laboratory. I hope that answered your question.
Yeah. One final question. Will you demo how to do a pickup impression with existing partial for fabrication of a new crown?
You demo how to do a pickup impression with an existing partial.
So like retrofitting.
Yeah.
New crown.
I don't have a partial. I do not have a partial, but that would probably be a really good topic to include in another presentation. And I am making a note to myself, and I'm saying it out loud so Brittany and Jessica can hold me to this. As part of our follow-up, I actually have an NDX document with 3 different recommended ways to scan for a crown under an, and I'm sorry, the question went away now, to scan for a crown under an existing partial. And I believe that's what you just asked. I just don't happen to have a partial to do the scanning. Ideally, I like to build up, well, let me take a step back. Typically, the tooth that's getting a crown under an existing partial is broken, and that's why it needs a new crown. Or there was tremendous decay under an existing crown. So I like to build it up with a little bit of composite, place the partial over top of that composite when it's still a little tacky to get an imprint of the clasp or rest seat from the partial, and scan, take the partial out of the patient's mouth and scan that mock buildup with composite as the pre-treatment scan. And then I ask the lab to duplicate the crown with the anatomy from that pre-treatment scan. I don't know if you have a favorite way, Brittany, but that's what's worked well in my hands.
Oh, no, definitely. I agree. Great question. And that's definitely something that's a topic that we can go more in depth in as well in the future.
There's lots of opinions on that one.
We do have another question. Thank you so much for your guys' participation tonight. What do you do when you can't scan the lower arch, even when you're doing four-handed dentistry?
You know, I do not sell scanners. I work for a dental lab, NDX, of course. And because of that, my general philosophy in dentistry is you use the materials that are in the best interest of that prosthesis that you're making for the patient. So if the patient is that challenging, sometimes you're going to need to go to PVS, or you're going to take, you know, some sort of an alginate preliminary impression and ask for a custom tray. And there's nothing wrong with that. You know, I know once we go digital, we want to like keep everything digital, and usually we can. So, you know, think of that 80-20 rule. If you're able to do 80% of your dentistry without resorting back to PVS, you're doing a fabulous job. And as I mentioned earlier, you're going to continue to see the evolution of the software really improve dramatically, I think, over this next 6 to 9 months when it comes to edentulous scanning. Okay, so no open questions. No open questions, is that right?
That's right.
Okay. So you can still see my screen. So I'm going to close out the scan and I'm going to go to a new prescription. Okay. So if we were going to set up the prescription, the RX, to scan for the denture, and I'm just going to So of course, we always need to put our patient information in, and we're going to scan under restorative. I can go back to notes, but I don't have to identify anything on the tooth diagram, and then I can go. Oh, typo there. Okay, so I'm set to scan the upper. I'm still always going to start on an occlusal surface of one of the denture teeth. Remember, we start on the occlusal surface because it has the greatest amount of data points. And that's really important when we're going to stitch these different images together. So I'm going to start the scanning just a little bit. And then I'm pressing and I'm holding on the screen. No. I want to disable the AI. I can see that my touch screen is not being very touch sensitive tonight. There we go. So the very last icon is disable AI. And again, you have to do it quickly. There we go. And then I'm just going to continue with my traditional scanning. Okay, so I'm doing the occlusal surfaces. Remembering that we do not necessarily need the tongue side of the palate. Now I'm going to go ahead and rotate to the buccal. And this already has that wash impression in it. And I'm going to finish with the intaglio. So similarly, when we're doing occlusal, lingual, buccal on natural dentition, we're going to do occlusal, lingual, buccal on the denture as well.
I would also like to add as well that there really is not any indicator that we have disabled the AI cleanup, aside from holding our fingers on the screen again to see the word enable.
Yes, good point. Then I'm going to wrap back up to the incisal edges of the denture teeth before rolling to the intaglio. So I like to start on the posterior. Again, the wand itself needs to touch the material that you're scanning. And as I mentioned earlier, it's a slow, methodical process. I've met some wonderful assistants that are just fantastic at this. Okay, now from the posterior, I'm going to move right down the center of the palate. And then try to connect to the left and to the right. And on the intaglio of the denture, if you have a little section that it is, usually it's a little deeper, and that's why it's difficult to capture. You can also use the fill tool to get that as well. So again, we don't have the tongue side of the denture. That's okay though. We don't need that for the fabrication of the new denture. We have all the occlusal surfaces, buccal surfaces, which is what we will need for a bite registration. And then really what I wanted to showcase to you tonight was the intaglio scanning of that wash impression.
It can be done.
It can, and it's not easy, or it certainly isn't easy for me. And I think it's my brain, you know, it wants to work faster than that. But as with everything we do in life, right? Practice makes perfect.
We did get one question.
Yeah.
Are we able to utilize the fill tool when we have AI disabled?
I'm pretty positive you can. So let me touch on it. And I thought I had a little hole somewhere. Yeah, like a little blue hole right there over like number 7 in the gingival. Yeah. There you go. So if I do fill.
Now we do have to remember, because of all of the data that this scanner captures per second, which is 6,000 images per second that it's capturing, the fill tool will take some time to load.
Yes.
But it can most certainly be used.
It does. So I'm going to let it continue loading, right? And see how we do here. Because sometimes it really can take like 10 minutes to do it on my scanner, because I have the Element 1. On the E2, it's a little faster, and on the E5, it's even a little faster than that. But to answer your question, yes, we saw that it activated on there. So I think we're good there. If we don't have any other questions specific to something on my scanner, I want to be respectful of your time, of course, and sort of stop the share and go back to the PowerPoint.
Oh, look at that. It's done.
Yeah, there you go. Yeah. So like these little areas here that are now encircled in red, if that was in the intaglio, you could pick that up. So pretty cool.
Wonderful.
So let me stop the share on that one, and then I'm going to reshare back up. Super. Okay, so I had left off with how to do screenshots. So we talked about that. And, you know, certainly as additional questions come up, feel free to put them in the chat or to contact us after the fact as well, right? So this is an upcoming webinar that we have similar to what we did tonight, except it will be on trios. And let me get myself, hello again. And then after that, we will have a series of presentations. I'm trying to, some live events.
These are some of our live events in the NDX Education Center in Jupiter, Florida. They are complimentary for attending. The first one is going to be in October. It is the 21st and the 22nd with Dr. Fasil Qureshi on guided surgery and prosthetics for the terminally dented patient and immediate full arch reconstruction. And then we have Dr. Mark Hyman coming to us in November 4th for a day presentation And he's going on cases that haunt us, how to react, rebound, and recover from clinical failures. So feel free to screenshot those QR codes or the HTMLs, and we'd love to see you down in Jupiter, Florida.
Yeah, yeah. I love the QR codes. I love being able to scan QR codes from computer screens. It's pretty awesome. And Dr. Hyman did not pay me to say this, but he really is a fabulous presenter. If you haven't had an opportunity to experience his presentations live. And then this is really just, you know, a thank you from us. Brittany, myself, Brenda, Bannister, and the entire NDX team we're really honored to be able to do this type of education with you. It's near and dear to our heart. As I said, we're always learning. It's an evolution, and we can't do this without feedback from you and without the experience of working with you, right? That's how we all get better, is collaborating and working with each other. So truly, thank you. Thank you very much.